for being at the meeting in person. But hopefully I will give you now an update on what's new in diabetic neuropathy. These are my disclosures. And really, my talk is in two halves. One is to provide you with the latest evidence in terms of therapies that will disease modify, that is, improve the underlying nerve damage. And the other is both based on current and future treatments for painful diabetic neuropathy. So if we look at things that we can do to help improve diabetic neuropathy, then I would refer you to this study that we've done in the Arabian Gulf region of over 3,000 patients, where we've assessed the risk factors for diabetic neuropathy. And what we show is that poor glycemic control, hyperlipidemia, hypertension, being obese, being less physically active, and smoking cigarettes are 6 key risk factors for diabetic neuropathy. If we look at poor glycemic control, then actually there are certain drugs that we are beginning to show are really changing the underlying disease. What are they? Well, first of all, GLP-1 therapy. So the first clue came from a sub-analysis of the LEADER trial, which was actually with liraglutide, which I think is a poor cousin of many of the GLP-1 agonists we have at the moment. But nevertheless, what this study showed is that whilst there was not a reduced risk in people developing foot ulcers during the study, there was a significant reduction in people who had an ulcer going on to have an amputation. And this then led us to a study that we did in Qatar, where we looked at exenatide once weekly with pioglitazone or basal bolus to try and see if actually these treatments were regenerating nerves. And we did that by taking patients with type 2 diabetes who were poorly controlled on metformin, on sulfonylurea, with HbA1cs of excess of 10%. Once they were randomized to exenatide and pioglitazone or basal bolus, you can see that the HbA1c dropped beautifully to around 7%. We then utilized the technique of corneal confocal microscopy to actually image nerve fibers to see if they were regenerating. And what we showed is over 12 months that, in fact, in both arms, when you got improvement in glycemic control, that there was regeneration of nerves. And when we measure this, you see fiber density, branch density, and length improves significantly in patients who have improved their glycemic control. We have now got an ongoing study with semaglutide, where we actually show that people who go on semaglutide once weekly clearly lose weight, around 105 kilograms dropping to just below 95 kilograms. Their HbA1c improves, as does their triglyceride levels. Symptoms assessed by the DM4 also improved. And although this wasn't significant, I think that's because there was quite a big, variability in terms of the DM4 score. However, when we look at their corneal nerves, again, corneal nerve fiber density and fiber length improved, but not significantly at 6 months. However, branch density improved significantly at both 3 and 6 months, indicating that there is actually regeneration and repair of nerve fibers in patients with diabetes and patients with obesity. More recently, we've just published a study from India where we have looked at the effects of dapagliflozin on small nerve fiber regeneration in diabetic peripheral neuropathy. 22 patients were randomized either to 10 milligrams of DAPA or standard of care. And in both arms, actually, there was a reduction in HbA1c, which was comparable, about 0.53 and about 0.57%. When we looked at the traditional measures of diabetic neuropathy, like MNSI, VPT, actually, it didn't improve. And in fact, if we had only done the study with these two measures, we'd have said, well, it's negative. However, we've used more sensitive markers like skin biopsy, and in there we see that there is, in fact, an increase in intraepidermal nerve fiber density in both arms, and corneal confocal microscopy, you can see that there's actually increased corneal nerve fiber density, increased corneal nerve fiber length, and branch density and fiber density, as well as length, in particularly the dapagliflozin arm. If we then look at obesity and physical activity. Well, we now show that physical activity may help repair nerves. So we had a cohort of patients with type 2 diabetes who were generally sedentary, and we had a cohort who walked 30 minutes of walking 3 times a week. We followed them up using corneal confocal microscopy over 2 years. And what we showed is that if you were physically active, the blue, then actually your nerves regenerated. So there's an increase in corneal nerve fiber density, less of a decrease in corneal nerve branch density, and an increase in corneal nerve fiber length. Whereas if you were physically inactive, you can see there was constant loss of these nerve fibers. For blood pressure, unfortunately, we did this study many years ago, and we didn't have corneal confocal microscopy, but nevertheless, we have previously shown that if you take patients with type 2 diabetes, put them on an ACE inhibitor, even though they're normotensive and had no microalbuminuria, then actually you had an improvement in nerve conduction, M wave amplitude, and F wave latency. If we then look at hyperlipidemia, in particular, hypertriglyceridemia, it seems to be the major driving risk factor. And so there is a study from Australia using oral omega-3 in actually type 1 diabetes, not even type 2 diabetes, where they looked at MNSI, MDNS, quality of life, nerve conduction, median nerve excitability. Multiple endpoints all showed no improvement in after 180 days of omega-3. However, corneal nerves repaired within 180 days, even at 90 days with omega-3. So there was increase in corneal nerve fiber length, increase in nerve fiber density, and significant increase in corneal nerve branch density. The other drug that is not used that often, why? Because we've got perfectly good drugs like statins and now the PCSK9 inhibitors, which show an impressive effect. But fenofibrate in the cardiovascular outcome trials didn't do very well. These are sub-analyses of those same trials that have looked at retinopathy, nephropathy, and in fact, neuropathy. So this is one particular sub-analysis published in the Lancet showing a 50% reduction in minor amputations in people on fenofibrate. And nobody really knew what the benefit or how this benefit was occurring, but most people thought it's a vascular benefit. However, we now have got a study from Singapore, 30 patients with type 2 diabetes given fenofibrate 100 to 300 milligrams daily for 30 days. What did we find? Reduction in triglycerides from 1.8 to 1.4, but within 30 days, increases in corneal nerve fiber density, regeneration and repair of corneal nerves. If we look at painful diabetic neuropathy, we know that in the kind of Europe, USA, it's about 21% of people were affected. What's the treatments? Well, the treatments really are either at the periphery, which we've got very few treatments, approved treatments, and then really, so you can see capsaicin may work peripherally, local anesthetics, non-steroidal anti-inflammatories. Then most of the approved treatments come at modulation at the spinal cord level or at the brain level. At the spinal cord level, ascending inhibitory pathways or ascending pathways are blocked by alpha-2 delta ligands like pregabalin, gabapentin, the tricyclics, tramadol, and opioids. There is, however, a brake system called the descending inhibitory pathway, which if you enhance, you block the signals going up to the brain. And this, of course, is achieved through SNRIs, tricyclic antidepressants, tramadol, and opioids. So what is the evidence that any of these drugs work and whether or not they actually work better than any others? Well, the most recent data is basically comparing these 3 different treatments. Amitriptyline, 75 milligrams, duloxetine, 120 milligrams, pregabalin, 600 milligrams. What does it show? Yes, there is a benefit, but pretty much equal. No difference between amitriptyline, duloxetine, and pregabalin. So, is there something new around the corner? There is. And this is actually some old data showing the potential effects of NaV1.7 and 1.8 in modulating pain. And it arises from a study published in Nature 2006, where a geneticist actually studied a family with derived from actually a patient who had been seen while this geneticist was on holiday in the northern areas of Pakistan, who saw a child walking on coal, had sacral ulcers, had a Charcot foot, And when they sequenced the genes from this patient and the family, what they found is that there were two families, and they had a mutation in the voltage-gated sodium channel, 1.8. And because there was a mutation there, this sodium channel wasn't working. And because this wasn't working, the patient felt no pain. Carbamazepine, of course, is a voltage-gated sodium channel blocker. And now there are multiple companies who are developing voltage-gated sodium channel inhibitors. So ion channel modulation, I think, will become more prevalent, i.e. new drugs. And why? Well, I think one of the big drawbacks of many of the current drugs we have that are approved is not that they're not effective, but they actually cause side effects. So, but if you can modulate the ion channels in the periphery, it has no side effects. And in fact, there is a study with a sodium channel blocker called suzetrigine VX548 in painful diabetic neuropathy, which has compared the benefits and the side effects compared against pregabalin. So what you see is comparing low dose, mid dose, and high dose with 100 milligrams of pregabalin 3 times a day. And you see that pretty much, maybe a little bit better with VX548, but pretty comparable reduction in pain. And it occurs after maybe 1 week start to occur, and it continues over 12 weeks. But the key difference is the side effect profile. In the pregabalin arm, you can see there was problems in terms of weight gain, headaches, dizziness, somnolence, but in the peripherally acting sodium channel blockers, nothing. Pilavapadin is another, I would say, it's a new drug with multiple mechanisms of action. What are they? Well, it's an adaptor-associated kinase 1 inhibitor. And it not only blocks recycling and reuptake of neurotransmitters, much like, say, pregabalin or gabapentin do, but it also has neurotrophic effects and anti-inflammatory effects. And when used in a study called Progress Study against pregabalin, gabapentin, and duloxetine, was allowed in use, what you got is actually an additive effect of further reduction in pain compared to placebo, which was significant. But sometimes obvious condition treatments are the most difficult to grasp. What do I mean? Well, my good old friend vitamin D. What we've shown, and Solomon Tesfaye in Sheffield has shown, is that people with painful diabetic neuropathy have lower levels of vitamin D. And in fact, if you have a level of vitamin D less than 20 nanograms per mil, your odd ratio for painful diabetic neuropathy is almost 10-fold increased. Even if your vitamin D is better, and it's less than 30 nanograms, the risk of painful diabetic neuropathy is 5-fold greater. So, does treating people with vitamin D improve painful diabetic neuropathy? Well, this particular study was done in Pakistan, and I can see there's a high use of vitamin D in Pakistan, and because of that, actually even at baseline, these patients had a vitamin D level of 31 nanograms. When 600,000 international units was given of IM vitamin D3, the level went up to 46 nanograms, and pain scores were significantly reduced. Quality of life was significantly improved. And in fact, now as a go-to, I use vitamin D3 orally, 50,000 units daily for 10 days, and then 50 to 100,000 international units once a week. Another drug, well, is it a drug? Oral B12. I know it's highly used in this part of the world, but I wasn't that convinced that this is something that can work in painful diabetic neuropathy until I saw this study from Greece, where they took patients with a vitamin B12 level of actually 232 picomoles per liter. They gave them vitamin B12 orally, 1,000 micrograms, and it went up to 776 picograms or picomoles per liter. What happened then? Well, MNSIQ improved, quality of life improved, pain scores went down, and nerve conductions improved. Whereas in the placebo group, you can see nothing much happened. In fact, MNSIQ got worse, and the pain scores got worse. And nerve conductions, again, got worse, actually. So, in conclusion, I hope I've shown you that the eye is the window to the soul. Why? Because corneal confocal microscopy, you can see, is increasingly being used to show regeneration and repair of nerves in multiple different interventions, whether it's GLP-1, whether it's SGLT2, and it can also be used to assess painful neuropathy. Thank you.